Hi, good day. I hope everyone is doing well today. My name is Paul Nyquist. I'm a professor of neurology, general internal medicine, anesthesia, critical care medicine, neurosurgery at Johns Hopkins University. And I'll be presenting our chapter from Neurocritical Care today with the first author of Lauren Kaufman. And I'll be discussing the chapter and walking you through it with this PowerPoint presentation. The title of our chapter is Neuroinfectious Diseases. So one of the most important neuroinfectious diseases, one that's commonly known to everyone, is bacterial meningitis. And one of the first steps is making a good diagnosis. Most of us know what it is. It's meningitis defined as a clinical syndrome. There's fever, nuchal rigidity, altered mental status, headache, nausea, vomiting, emesis. And then there's the important Kernig's, which involves holding the head and bending the knee, and Brzezinski's sign, which is just pulling the head forward. Both of these are not neither sensitive nor specific, but can be helpful in certain circumstances where there's a change in mental status without fever. It's a neurologic emergency. It requires your rapid initiation of diagnostic testing with empiric treatment, and the diagnosis relies upon the sampling of cerebrospinal fluid. And there has to be care in the setting of elevated ICP. Often there could be a brain abscess or other injuries, and you just want to make sure you do a CT head first to make sure that you're not going to increase the risk of herniation during the lumbar puncture. So the CSF is very important, and initially it should be sent for cell count with a differential that includes a protein, gram stain, a culture, and now with PCR technology, many institutions develop PCR not just for viral entities, but TB and other entities as well. You should always consider that since they usually have very high sensitivity and specificity. You should have blood cultures prior to administration of antibiotics, and serum glucose at time of CSF is also quite critical. Classic CSF findings include elevated opening pressure, elevated protein, exocytosis with polymorphonuclear predominance in the white cells, hypogalacturia, and then the blood glucose ratio to CSF ratio of less than 0.6. Lactate has now become increasingly important, particularly in patients with complex infectious diseases in the setting of retained material such as external ventricular drains. And again, you need to identify the organisms. You use a gram stain, culture, and PCR. And then bacterial culture is always useful to narrow antibiotic therapy. The International Infectious Disease Society recommends for empiric therapy that use vancomycin, a third-generation cephalosporin, and ampicillin if indicated. That's usually indicated for people who are immune suppressed or individuals over the age of 50. If you suspect herpes simplex, you should initiate acyclovir immediately and wait for PCR to confirm or not confirm the infection. And then steroid therapy has become more common. It's based primarily on data from pediatric patients. It's known to decrease the risk of incipient deafness. And then it's also, there have been a couple of studies in adults that are borderline. It's now considered something that may become more associated with standard care. The first dose should occur 10 to 20 minutes prior to or concomitant to antibiotics. And the dosing is 0.15 milligram per kilogram every 6 hours for 2 to 4 days. Here is some nice graphs of different types of organisms. The most common organism is strep pneumo. Neisseria meningitis should always be considered because it's an issue of being quite contagious in closed communities, such as young people who are in military service. Listeria monocytogenes is important to consider in patients who are immune suppressed or older. It's also been associated with food contamination. Most of the time you treat from 10 to 14 days. However, exceptions to that are Pseudomonas, in which you can treat from 14 to 21 days, often associated with in-hospital acquired infection, usually using vanc and something like cefepime or ceftriaxone. With Pseudomonas, you can also consider expansion up to meropenem or initial therapy with meropenem. There are some unique infections associated with CS shunt, which includes Staph aureus, gram-negative bacilli. The other ones are things that most people already know. This is a nice, handy table to refer to if you're concerned about other subsets of the population. Viral encephalitis is also an important entity. It should be differentiated from a multitude of other similar presentations. Usually when someone comes in and they have a fever, you expect viral encephalitis, and you rule out bacterial meningitis. Other entities to be worried about are post-infectious encephalitis, post-immunization encephalitis, and acute disseminated encephalomyelitis. vasculitis and paraneoplastic syndromes. These are usually autoimmune syndromes, and they're often associated with NORS, or new onset refractory status epilepticus, which has, a series of subsets of infectious or easily identified entities, then an autoimmune entity, and these are all autoimmune types of encephalitis, and then a non-autoimmune, or a relatively benign syndrome that's associated with prolonged seizures that usually resolves after a period of time. History is very important. You want to know about travel, immunosuppression, occupational exposure, and vaccine history. And most people assume, until ruled out, that there's a bacterial component, so people will usually begin empiric antibiotics. You need to get a CT to rule out a mass lesion of severe cerebral edema prior to obtaining your CSF. CSF should be sent for routine labs, and then PCR testing for all the DNA viruses, HSV1, 2, VZV, EBV, enterovirus, and other viral serologies. There are things like Western equine encephalitis. West Nile is important in our region in particular during various seasons, such as the summertime when mosquitoes come out. There's typically a mild to moderate pleocytosis. Sometimes you can have just as generous and aggressive pleocytosis you would with bacterial. Usually that's not the case. Usually there's a very small number, maybe 40 to 100 lymphocytes. The glucose is typically normal with some mildly elevated protein. And skin lesions may occur with this, which is, of course, a risk for zoster, so you make sure that you culture those. And then magnetic resonance imaging with and without contrast to rule out other types of skin lesion-associated viral infections like herpes 1 and 2. Electroencephalography is also important to rule out non-convulsive seizures. And again, here are some of the agents. You can see we have HSV 1 and 2. HHV 6 is more common immune compromised. It's a relatively recent discovery over the last 10 years. It's seen a lot in transplant patients. Varicella zoster is always on the list, often not associated with skin lesions, though typically it is. Epstein-Barr virus can be a reemergent virus, particularly in patients who have exposure to saliva and community, or young people who haven't been exposed to the virus before. CMV can reemerge in the immunocompromised patient as well as neonatal patient. And West Nile virus, Eastern equine encephalitis, Western equine encephalitis, and various others, flaviviruses can also present on a seasonal basis. Another important issue is brain abscesses. This usually occurs from a focal parenchymal infection. Transmission is usually contagious, spread from a primary focus. Common sites are paranasal sinusitis, otitis media, mastoiditis, penetrating head trauma. 20% of the cases can spread hematogenously, and the pulmonary source or cardiac source or right to left shunt. The mouth, skin, and gastrointestinal tract may also be observed. There's a number of stages of brain abscess formation, including cerebritis, leading to perivascular inflammation surrounding the necrotic center. After the necrotic center reaches maximum size, it forms a capsule, and this eventually becomes supplied by blood and has vascularization, which is sort of the terminal stages of the capsule formation. Once you reach this stage, often the abscess will start to increase in size over time, depending on the organism, and it can be it's always difficult to treat with antibiotics. It usually requires surgical resection. Brain abscess occur in post-neurosurgical cases, and they usually associate with colonizing skin bacteria, including Staph aureus, Staph epidermis, and gram-negative bacilli. They usually present 1 to 14 days after surgery. 60% of the patients have a focal neurologic deficit or altered level of consciousness. Risk factors include immunocompromised neurosurgery head trauma, and it's often misdiagnosed as a tumor stroke. And lumbar puncture is always performed, and there always has to be clinical suspicion of meningitis and a worry that there could be a risk of herniation, particularly if they have focal neurologic signs. So a CT is always essential. You want to have, to treat a brain abscess, it's always great to have surgical aspiration to reduce both the size of the abscess and then also to identify the organisms. With modern stereotactic neurosurgical techniques, can virtually access any abscess, with a diameter less than 1 centimeter, often less than 0.5, depending on the skill and location of your surgery. Head CT has a high sensitivity for abscess, 95 or to 99%, but it has very poor specificity. Often the head CT, if is negative, you can still have an abscess. Vasogenic edema around the abscess is hyperintense on T2 weighted images. The center is isointense or hyperintense, and the capsule is hypointense. There's early contrast enhancement in the stage of cerebritis, and the DWI is hyperintense with a low ADC. Medical therapy alone is usually ineffective, but sometimes in in small abscesses less than 2.5 centimeters, you may go that route due to the location, the complication with other illnesses, immune suppression, inability to do surgery, ventriculitis, and hydrocephalus that require CSF shunt. Smaller abscesses are now surgically treatable because of stereotactic surgery. Again, 1 centimeter seems to be the cutoff. Sometimes it's 0.5 centimeters. Empiric antibiotic therapy should begin immediately. Empiric treatment for patients who have undergone neurosurgical procedure head trauma with skull fractures usually includes vancomycin plus a fourth-generation cephalosporin, i.e. cefepime, and Flagyl for 6 to 8 weeks. There's always fear of atypical organisms, particularly since so many of these organisms will come from the nasals or paranasal sinuses as well as the mouth. And then always have an ID specialist follow around. Missed opportunities to treat with appropriate antibiotics can have grave consequences. Post-neurosurgical infections are very important, particularly in neuro-ICU. These are recorded by almost all state agencies, and all neurosurgical programs will follow these types of infections. They usually occur 1 to 8% of all surgical cases. In order to do this, there are some numbers that people often throw around, such as 100,000 bacterial organisms per gram of tissue required to do this. It's more of a way of visualizing the transfer of organisms to help people improve their technique to avoid infections. Common manifestations are meningitis, brain abscess, subdural empyema or epidural abscess. And then recent meta-analysis report a lower incidence of post-creectomy infections in North America compared to European countries, 2.2 versus 5%. Subdural empyema is another important infection in post-neurosurgical area. It affects 4% of neurosurgical procedures. It occurs in 1 to 8 weeks after surgical procedure, so it can be quite delayed. Laboratory abnormalities include elevated white count and positive blood cultures. Staph and gram-negative bacilli are the most common pathogens. Lumbar puncture, increased cerebral herniation, CSF protein and white blood elevations are important. CT usually reveal the subdural empyemas for our hypodense collections, and they always enhance. Management includes both surgical drainage and antibiotic therapy. In surgical drainage is performed in 96% of these cases, enables source control as well as identification of organism. And then we always start empiric treatment with vancomycin plus a fourth-generation cephalosporin, i.e. cefepime. Cultures are obtained surgically, and then therapy is always tailored according to the organism. Usually, therapy goes on for 3 to 6 weeks. Ventriculitis is also another important infection we see in the ICU. The risk of developing ventriculitis increases with external ventricular drains. There's management of frequent CSF sampling helps prevent this. Infection has been reported in 8 to 40% of patients receiving a CSF shunt. This is highly variable based on age and time of shunting. Usually, children are subject to increased risk of CSF shunting due to their behavioral manifestations, the fact that they kind of outgrow their shunt and often puts traction on the shunt. Risk is increased in external ventricular drains. If you have hemorrhagic CSF, such as with aneurysmal subarachnoid hemorrhage, it's like 10% risk, and intraventricular hemorrhage 13.7%. Most common organisms are gram-positive organisms. They're skin contaminants. These include Staph epi, Staph aureus, Propionibacter acnes, and Streptococcus. Fungi can also occur, and this can be very problematic if there's hardware is retained. And there's always risk of gram-negative organisms such as E. coli, Klebsiella, Actinobacter, and Pseudomonas. And gram-negative will cause up to 25% of all infections. In traumatic brain injury patients and following brain surgery, aerobic and gram-negative bacilli includes Pseudomonas species, Staphylococcus epidermidis, and Staph aureus. Diagnosis by ventriculitis usually includes mental status change. All the usual infectious signs include meningitis and altered mental status. They're often associated with fever. Positive CSF cultures with absent symptoms should lead the clinician to suspect colonization or contamination. If you have the symptoms, it's usually supported by an isolated positive CSF culture with normal SCSF findings. External ventricular contamination is defined by an isolated positive CSF culture and or gram stain. Expected CSF glucose and protein profile and CSF cell count are associated generally with bacterial infections, which would be a low glucose, high protein, and then a CSF count, usually with PMLs. Ventriculostomy colonization is defined by multiple positive CSF cultures and gram stains with expected CSF profiles and cell distributions. And gram stain identifies the cause of bacterium in 60 to 90% with a 97% specificity. So it's usually a pretty good measure of what's happening inside the CSF. A single positive culture without any kind of symptoms should not trigger a reflexive diagnosis of ventriculitis. You don't want to overdiagnose it. You treat with CSF with antibiotics, it perpetuates infection. Many of the external ventricular drains have biofilms at their tip, as do central lines, and so you often will have false positive cultures. The likelihood of having a positive gram stain varies by pathogen. So for strep pneumo, you bury 90% of the cases will actually have a positive gram stain. Haemophilus influenza, the same. Diphtheria meningitis, 75%. When you get into the gram negatives, often they won't have a positive gram stain. In only 1/3 of the cases with Listeria monocytogenes will actually have a positive gram stain. Lactate is becoming more and more useful. Often you'll have a situation where you have put an external ventricular drain to someone who's already had a brain injury, such as a bleed, and so their white count is already elevated. It's hard to judge with that. Often they have alteration of the protein, and then the glucose is equivocal or not helpful. And the patient may have some signs of infection, including increasing lethargy without fever. And then you really want a new tool, so to speak, to see if you can help differentiate the infected from the non-infected. And CSF lactate is something that we use more frequently in the ICU now. In general, if you have CSF lactate concentrations greater than 4.0 millimolar per liter, that's suggestive of infection. Now, in one study, relatively small, it's case series, classical clinical study, CSF lactate concentrations of greater than 4.2 millimole were considered to be positive discriminating factor for bacterial meningitis with a sensitivity of 96%, specificity of 100%, positive predictive value of 100%, and negative predictive value of 97%. This was a small study. It's a single study. It wasn't a randomized study. It was a case series, so you have to take these numbers with a grain of salt. However, in our practice, we find that CSF lactate is very helpful, particularly in those complicated infections where you have hardware, blood, and other features that may cause artificial elevation of the white blood cell count not related to infection. The treatment includes consideration of the patient. The ventricles are in an immunologically isolated place. There's often infected hardware which should be removed or replaced if possible. And these factors will limit success with recurrence in weeks to months often in situations where the hardware is reinserted because the patient has ongoing hydrocephalus. And then you want to do targeted antimicrobial therapy from pathogen identification on CSF. Empiric therapy is vancomycin, cefepime, and vanc plus ceftazidime or vancomycin plus meropenem are also alternatives. In most cases, treatment is continued for 10 to 14 days. For gram-negative bacillus, therapy continued for 21 days. Shorter course of 5 to 7 days when external ventricular device has changed. Fungal infections are a very special case and often require extra vigilance. Sometimes we will actually do intrathecal or transventriculostomy insertion of antibiotics. Often these are cases of fungal infection where the penetration of the ambizone is ineffective at reaching the CSF, or failure in immunologically impaired hosts with hardware who've had chemotherapy or who are experiencing senescence of their immune system. While there are a number of ways to do this, it has been successful for me and other clinicians in certain circumstances. This should be the last place to go in patients who absolutely have to retain their hardware and can't have standard therapy. And in these cases, we have often successfully defeated the infection, and patients have survived. I would suggest anyone who's thinking about doing this to talk to your pharmacist to figure out the perfect dosing and to look at some of the numerous articles online. Well, that concludes my talk for today. I hope you've gotten a lot out of this, and thanks for listening.